Assalamu alaikum. This is Dr. Sayyida Ali Fatima, and we are going to discuss pulmonary embolism today. The goals of today's presentation are we are going to discuss definition, types of emboli, pathophysiology, predisposing factors, diagnosis, management, pregnancy and embolism, and further learning projects. So, what is pulmonary embolism? Basically, pulmonary embolism is the blockade of any artery in the lungs by a substance that has moved from elsewhere in the body through the bloodstream. And this substance can be the following. It can be a blood clot from the deep veins of the legs. It can be a blood clot from the upper limbs by IV line cannulations. And it can be a fat embolus or amniotic fluid during pregnancy, or cancer tissue via metastasis from the veins and bone cement implantation syndrome. In that case, it's the bone cement. Predisposing factors. So there must be some predisposing factors. Some of them are strong risk factors, some of them are moderate risk factors, and the others are mild risk factors. Important ones are the strong risk factors, which are fractures of the lower limb, long bones basically, and fractures of the lower limb cause fat embolism syndrome. Previous history of venous thromboembolism, for example, history of deep vein thrombosis, or history of previous pulmonary embolism, or a female patient who has got history of amniotic fluid embolism, spinal cord injury due to immobilization, hospitalization for a heart failure or atrial fibrillation or flutter within 3 months. So the 3 months history is really important. If a patient who presents to you with a pulmonary embolism and you just suspect that a patient is having pulmonary embolism, you have a history that a patient was hospitalized for atrial fibrillation or atrial flutter or heart failure within previous 3 months, so you suspect him to be a high risk patient for pulmonary embolism. History of hip or knee replacement within 1 month, and major trauma within 1 month, and myocardial infarction within 3 months. Moderate risk factors include arthroscopic knee surgery, autonomic diseases, for example, systemic lupus erythematosus, many more, blood transfusion, central IV cannulations. Basically, central venous cannulations for prolonged periods are major risk factors for the pediatric population for pulmonary embolism. And intravenous catheters and leads, chemotherapy for cancer, congestive cardiac failure or respiratory failure. Basically, congestive cardiac failure or respiratory failure is the right heart failure, and in pulmonary embolism, it also causes the right heart failure. So it's an independent risk factor of pulmonary embolism. Erythropoietin stimulating agents and hormone replacement therapy. Erythropoietin related agents will increase the hematocrit and will thicken the blood, and it leads to probable causes of making thrombi and then emboli and then causing pulmonary embolism. Hormone replacement therapy, as well as OCPs. Again, moderate risk factors are in vitro fertilization, oral contraceptive pills, postpartum hemorrhage or postpartum period is itself a risk period for pulmonary embolism. Infections, खास तौर पे HIV, UTIs or pneumonia. So a patient who is already admitted in the hospital, and you know that he has got UTI and he is bedridden, you should suspect that he may have pulmonary embolism. You should have the venous thromboembolic prophylaxis being given to the patient. Inflammatory bowel disease, cancer, paralytic stroke, superficial vein thrombosis, thrombophilia, and many are some weak risk factors. Again, bed rest for greater than 3 days, only 3 days. A patient who is only on bed rest for 3 days is also predisposed to the venous thromboembolism. Diabetes mellitus due to micro and macroangiopathies, arterial hypertension, and immobility due to sitting, prolonged car or air travel, increasing this immobility due to the sitting in prolonged car or air travel is especially for the patients with cancer. Increasing age, and laparoscopic surgeries, obesity, pregnancy, and varicose veins. So we have done with the predisposing risk factors. So all these risk factors are those which you have to keep in mind when you see a patient, or in whom you suspect that he's going to have a pulmonary embolism, or if in which in those patients in whom you have a probable differential diagnosis of pulmonary embolism, you have to rule out all these predisposing factors. So, what is the pathophysiology? What happens? A thrombus becomes an embolus when it gets dislodged from its primary site, and it goes straight away to the heart, and it goes to the heart via inferior or superior vena cava depending upon its primary site. And when it enters the heart, it enters via right atrium. It enters via right atrium and it goes to the right ventricle, and then it goes to the pulmonary trunk. And if it stucks in the pulmonary trunk, it becomes a massive pulmonary embolism, or if goes further away to the peripheral pulmonary arteries, it becomes, not massive but pulmonary embolism. What happens when the forward flow of the blood from the right ventricle is inhibited by the blockade of the pulmonary artery? The right ventricle dilates, and when that right ventricle dilates, there is the right ventricular wall tension increasing, and right ventricular wall tension leads to increase in the pro-BNP and pro-BNP, anti-pro-BNP, both of them, uh, as well as tropi and the other cardiac injury biomarkers. What happens then? The right ventricle is dilated. Now, when it is dilated, it gets more time for systole as compared to the left ventricle, because of the fact that it is already dilated. It has got a lot of afterload, so it will take more time as compared to the left ventricle uh, for its contraction, for its systole. So the right ventricle's systole takes more time as compared to the left ventricular systole, and it goes into the left ventricular diastole. What I mean to say is that when the left ventricle is starting its diastole, at that very time the right ventricle is only being in the systolic phase. So what happens is that there is some bulge of the interventricular septum towards the left side, and left ventricle cannot dilate and cannot fill properly from the blood. When the left ventricle does not fill from the blood, uh, there is low cardiac output, there is low venous return, and hence the low cardiac output, and hence the low blood pressure. And when there is low blood pressure, patient is going to be hemodynamically unstable, and right ventricular oxygen demand is going to increase, and right ventricular wall is going to be ischemic, and it's going to have the hypoxic injury. So, how will you diagnose? The diagnosis is really important in this scenario, because it is not only clinical. We have got so many diseases in which we prepare a clinical diagnosis, but in this very situation we cannot do so, because the clinical presentation is very vague, very uncertain. So we have got multiple components of the diagnosis, in which the first of all is of course the clinical presentation, on which you make a suspicion of the pulmonary embolism, and then you are going to assess for some clinical probability pre-test criteria. And you have to avoid overuse of the diagnostic tests for the pulmonary embolism, D-dimer testing, and imaging studies, as well as assessment of the risk of early death. And then you are going to make a particular diagnosis, and then you have to manage the patient accordingly. What is the clinical presentation of a patient with suspected pulmonary embolism? Well, a patient who has got pulmonary embolism will present with dyspnea, shortness of breath. He will be short of breath, and he will, or she will be having maybe chest pain, or maybe pre-syncope or syncope, and hemoptysis in very rare and acute and very severe conditions, as well as hemodynamic instability. So, can you people make a differential diagnosis out of these clinical presentation problems? Well, we have got so many differential diagnoses in here. So, moving forward, we cannot make a definitive diagnosis out of these clinical presentations. As I previously said, that this clinical presentation is really vague, and if the vague clinical presentation is there, we have got other things to know, so that we can make a definitive diagnosis out of these things. And with this clinical picture, I can make a diagnosis of pulmonary edema, right heart failure, or chest pain, so MI, or hemodynamic instability, well, and hemoptysis. I mean, I can make a diagnosis of even at sometimes tuberculosis or any other thing, so we have got so many uh, differentiate diagnosis out of this clinical presentation. Before going to the other criteria for diagnosing this, I want to define hemodynamic instability. When we will say that a patient is hemodynamically unstable, well, there may be three conditions. A patient in cardiac arrest, as all of us know, what is cardiac arrest? This is a stop of heart beating and stop of respiratory center. So in the cardiac arrest, you will see a patient already in having cardiopulmonary resuscitation. So he is in cardiac arrest. We have to define the obstructive shock in the pulmonary embolism, because what is obstructive shock? One should know that obstructive shock is form of shock in which there is internal or external compression of the heart, due to which there is less forward flow of the blood from the right ventricle or the left ventricle, and so there is low cardiac output and the hypotension occurs. It contains so many other things as well, including cardiac tamponade, including tension pneumothorax, or in this case pulmonary embolism. So in obstructive shock, we can define obstructive shock by if you have a patient with systolic blood pressure less than 90 millimeters of mercury, or a patient who is on vasopressors to achieve a blood pressure of greater than or equal to 90 millimeters of mercury despite adequate feeding status. What does it mean that adequate feeding status is? That you have seen the central venous pressure which is adequate, or JVP is raised, and the patient is still hypotensive, so he is in obstructive shock. As well as the patient must have end organ hypoperfusion, altered mental status, cold, clammy skin, oliguria, and uria, increased serum lactate. The other clinical condition which we see in hemodynamic instability is persistent hypotension. What is persistent hypotension? When will you mention a patient with a persistent hypotension? A patient with systolic blood pressure less than 90 millimeters of mercury, or a systolic blood pressure drop of greater than or equal to 40 millimeters of mercury for 50 minutes at least. If a patient is there who has got low blood pressure of less than 90 millimeters of mercury for previous 15 minutes or more, and it is not caused by the new onset of arrhythmias or hypovolemia or sepsis, and if it's not being explained by these particular conditions, you will label the patient as persistent hypotension. Now, as I previously mentioned in the previous slide, that the clinical presentation is vague and uncertain, so we have got other probability scores and pretest probability scores. What these are? These are the Geneva score, revised Geneva score, Wells score, and revised Wells score. How heart rate has got two divisions, 75 to 94 and greater than 95 beats per minute. Also, in Wells scoring, he has told us that there must be some recent surgery or immobilization, but for how long, he has not defined it, so it's vague as well. That's why now Geneva score is more popular and it's being. Now, how can we avoid the overuse of diagnostic tests? With with these signs and symptoms, and with having Geneva and Wells score into your clinical practice, we have to rule out that is there pulmonary embolism, is there or not, because if you are not going to rule it out, you are going to have multiple expensive tests and in laboratory investigations which are really expensive on part of patient as the hospital and economy. So we don't want them. So we have got criteria, which is the pulmonary embolism rule out criteria, or PERC score. It has got 8 components, including age, pulse, saturation, at room air, and no unilateral leg swelling, no hemoptysis, no recent trauma or surgery, no history of venous thromboembolism, or no oral contraceptive pills or hormone use. Imaging studies uh, include different types of imagings. Uh, the foremost important is CTPA, which is CT scan of pulmonary angiography. Then we have planar ventilation perfusion scan, ventilation perfusion spectrography, and pulmonary angiography, echocardiography, and compression deep in duplex scan. So their own values. In this slide, we can see CTPA, strengths, weakness, limitations, or radiation issues. The important thing in this slide, which is an extra thing and which is very important as well, that pulmonary angiography is a gold standard. Historically, it is gold standard, but it is very invasive. On contrary, CTPA is less invasive and it is readily available and less expensive as well. But we have got other things as well, which is planar VQ and the VQ SPECT. Now, the problem in VQ SPECT and the planar VQ is person difference of the interpretation of the results and radiation exposure. But the good thing in both of these uh, perfusion scans is low incidence of radiation exposure. As you can see in the planar VQ scan and the spectrography, we are exposed only to 2 millisieverts of radiation, on contrary to the CTPA, which has got 3 to 10 millisievert radiation, and on contrary to the pulmonary angiography, which has got even more radiation exposure, which is 10 to 20 millisievert. Echocardiography is done for evaluating the right heart, you know, right heart morphology and right heart strain. Of course, when there is a pulmonary embolism, patient will die of right heart failure. So it is for most important in its aspect that echocardiography will tell you on the bedside, transthoracic echocardiography on the bedside, it will tell you about the right heart condition. There are some signs on the echocardiography for pulmonary embolism. These are, you can see enlarged right ventricle in the parasternal long axis view. You will have dilated right ventricle as compared to the left ventricle and the McConnell sign. It is called as McConnell sign. And you can see the flattened interventricular septum due to, bulging of the interventricular septum towards the left side from the right side, because the right ventricle is dilated and it's big due to increased afterload. And what else you can see? You can see distended inferior vena cava due to the increased volume status in the patients. We have a 60-60 sign, which is coexistence of acceleration time of the pulmonary ejection and mid-systolic notch with mildly elevated peak systolic gradient at the tricuspid valve. Well, in worse conditions, you can also see a blood clot in the right heart. So these are some echocardiographic findings. Okay, so we have got PESI. What is this? And why is it needed? PESI is the Pulmonary Embolism Severity Index. You have to stratify the risk and severity of the disease. You can, how would you determine a patient who is having mild pulmonary embolism, or, who's having moderate or high risk pulmonary embolism? So we have to stratify this as well. So this is PESI, which is the pulmonary embolism severity index. It has got, again, almost similar things as in Geneva and Welch score, like male gender cancer, chronic heart failure, chronic pulmonary disease, pulse rate, systolic blood pressure, respiratory rate, temperature. It has got all the vital signs in it, as well as altered mental status and arterial oxygenation. Can it can be determined by the stratification of the risk into 5 classes, class 1 to 5. Class 1 has got 30-day mortality of 0 to 1.6, and while class 5 has got about 25% of the mortality. And in simplified version, we have just divided it into two. If the 0 points are there, they have 30-day mortality of 2.1. and in greater than 1 point we have got 13.2% mortality. So we have classified the pulmonary embolism severity on basis of different clinical as well as investigational criteria. If the patient is hemodynamically unstable or clinical parameters of pulmonary embolism severity index, right ventricular dysfunction on transthoracic echocardiography or CTPA, or elevated cardiac troponin level. So all these four indicators of the risk, they stratify and put the patient into the high, intermediate or low mortality cases of the pulmonary embolism in 30 days in hospital mortality. We have to memorize this, and we have to know that a patient who is hemodynamically unstable, who has got high grade of PESI grade 3 or to 5, and who has got right ventricular dysfunction on the transthoracic cardiography, and who has got raised drop eye levels, he is a high risk patient for 30-day mortality. And in the next three, intermediate and low risk, we have got other things, but not hemodynamic instability at least. Done any D dimers or CTPA immediately. We have started with the TTE. Patient who is hemodynamically stable, you have to start a patient with clinical assessment probability. And if you see that patient is in lower intermediate clinical probability, only then you have got to go for the D-dimer testing. And if the patient is, not, he's probably high clinical probability or PE likely, then you have directly to go to CTPA. Do not go for the D-dimer test. Okay, so the D-dimer test is positive, CTPA करवाएंगे, and if the CTPA is positive, pulmonary embolism is confirmed, you have to go for a treatment. If it is negative, you don't have to go for any treatment. Okay, if on the first place D-dimer is negative, you do not have to go for CTPA, you do not have to go for any treatment, no treatment is required. And on contrary, if a patient is highly likely for pulmonary embolism, you have to go directly for CTPA and follow accordingly. How will you manage a patient with the with pulmonary embolism? Uh, it depends on the patient's clinical status. If a patient is hemodynamically unstable, you will start with the hemodynamic and respiratory support, which includes oxygen therapy and ventilation, pharmacological treatment of acute right ventricular failure, mechanical circulatory support and oxygenation, which is ECMO, and advanced life support in cardiac arrest. Also, you will go for initial coagulation and reperfusion treatments, which are uh, different drugs, anticoagulants, and the thrombolytics. Now you've known that this patient is in acute pulmonary embolism. You will start with anticoagulation, and if the patient is hemodynamically unstable, then you will start reperfusion treatment. And if the patient is hemodynamically not unstable, he is stable, then you have to go and check 1 and 2, which is clinical signs of pulmonary embolism severity or serious comorbidities, and right ventricular dysfunction. You see, if you have got right ventricular dysfunction, there is no other reasons for hospitalization, or family or the social support is there, and easy access to the medical care, early discharge home, and treatment. And if one is not true, then you have to hospitalize the patient. Okay, and the other probability is clinical signs of pulmonary embolism severity or serious comorbidity, PESI class 3 or 4, or then you have to do what? You have to distinguish the low from intermediate risk pulmonary embolism, perform troponin tests, and follow accordingly. If it is negative, you have to hospitalize. If it's positive, you have to reperfuse the patient. This is the right ventricular management, which includes volume optimization, vasopressors, and inotropes, including norepi and dobutamine, and mechanical circulatory support. We have got anticoagulation, different drugs, lomolecular heparin and fondaparinux, and thrombolytics. We have got recombinant tissue plasminogen activators, streptokinase, urokinase. There are different contraindications, and they're mentioned here. And pulmonary embolism in pregnancy can be venous blood clot embolism or amniotic fluid. And here is the algorithm. You will approach a pregnant patient who has got high pretest probability or intermediate or low probability and a positive D-dimer test. You will anticoagulate with a low molecular weight heparin. You will do a chest X-ray of a pregnant patient, and as previously noted that we have not done chest X-ray as yet, but we are doing X-ray chest in a female patient who is pregnant and who is a suspicion of pulmonary embolism. And the other thing you will do is compression, proximal duplex ultrasound if symptoms or signs are suggestive of deep vein thrombosis. You will do duplex scan of her legs, and if proximal deep vein thrombosis is present, you have to start the treatment. You have to continue the low molecular weight heparin at therapeutic dose. You have to assess the pulmonary embolism severity and risk of early death and refer the patient to the multidisciplinary team with the experience of pulmonary embolism management in pregnancy. Provide the plan to guide the management of pregnancy, labor, delivery, and postnatal and future care. But if a patient has not, if the proximal deep vein thrombosis is not present, then specifically you have to see the chest X-ray, review the chest X-ray. If the chest X-ray is normal, you have to go for a CTP or perfusion lung scan. If the chest X-ray is abnormal, definitely go for a CTPA. Well, it will rule out the pulmonary embolism, so no need of any other treatment. And if it is not, if it is conclusive of pulmonary embolism, again you have to go for the treatment. These are some estimated amounts of the radiation absorbed in the procedures used to diagnose the pulmonary embolism based on various references. I just wanted to mention in this very slide that a chest X-ray provides estimated fetal radiation and estimated maternal radiation of 1/10 of the maternal radiation, which is zero point 0.1 guy for the mother and 0.01 guy for the baby fetus. And if you're going for the CTPA, that is 3 to 10 for mother as a non-pregnant adult, but only 0.05 to zero point 0.5 of you know for the baby. So uh, you know uh, do not be afraid of up, going for a CTPA in a pregnant patient, because the baby is being exposed only to the amount even less than chest X-ray. So please do not go. Uh, do not be afraid of doing a CTPA in a pregnant patient who is suspected of having pulmonary embolism. Okay, long-term treatment, you have to see this slide. This is very bulky slide, but once a patient has been diagnosed with acute pulmonary embolism, you have anticoagulated the patient. You will have to follow up the patient for at least 3 to 6 months. If still dyspnea is present, you will do transthoracic echocardiography, and there must be determine the probability of the pulmonary hypertension, which is low, intermediate, or high. If it is high, you have to go for a VQ scan and then refer the patient to the pulmonary hypertension expert. If it is intermediate, consider elevated NT-proBNP, risk factors, other, and abnormal CPET results. And if it is low, you have to seek alternative causes of dyspnea and common cause of the pulmonary hypertension. On the other hand, if there is no dyspnea and there is no functional limitation, then you have to assess the risk factors for the CTEPH, and if none of them is present, focus on the anticoagulation and secondary prophylaxis. Advise to return if symptoms reappear.